Examination of goiter. To examine goiter, first of all, you assume the sitting position for the patient, and then the exposure will involve removing the head tie, having the neck exposed up to the upper chest, the arms, and the lower limb, the leg specifically. Man, please remove your cap. Keep it for her. Thank you. With the patient in sitting position, the head and neck and upper chest, upper limbs, lower limb exposed, you start first of all by examining the neck mass. For the neck mass, the examination will involve inspection, palpation, percussion, and auscultation. Secondly, you examine for eye signs. Thirdly, you examine some signs in the upper limb. And lastly, you examine some signs in the lower limb. So we start with the neck mass. You come in front of the patient, squat in front of the patient, and inspect the neck mass. If it is not so clear, you ask the patient to extend the neck a bit. Please raise your head a bit. Okay? You inspect the neck mass, note the site, you note the shape, you note the number, whether it's solitary or multiple nodules. You note the skin over the mass, and then you look at the surrounding, whether there are additional masses like lymph nodes. Then you ask the patient to swallow the saliva. Please swallow. And you observe the mass moves with swallowing. Swallow again. The mouth moves with swallowing. Please open your mouth. Bring out your tongue. You observe the mass does not move with tongue protrusion. It's okay. After that inspection is completed, you move on to palpation. Palpation is done in two aspects. First in front of the patient and then behind. In front of the patient, you check for differential wounds. You check, first of all, the arm with the dorsum of your fingers. Then you check the mass and back to the arm. Then you check for tenderness by using your right index finger to press on the mass while you are looking at the eyes of the patient. If there is tenderness, you will see some signs in the eyes. Then you check the extent of the mass by palpating around it. When you are sure the extent of the mass, you now check the size horizontally and vertically. After that, you check for skin attachment to the mass, and then the last thing you do in front of the patient is to check the trachea position. Please raise your head up, locate the trachea with your finger, and run your finger along. Here the trachea is deviating to the contralateral side. After that, we are done with palpation from in front of the patient. You go behind the patient. And patella hammer. Behind the patient, you continue with palpation. First of all, you position your hands such that the thumb is located in the occiput. The thumb is located in the occiput, with the other fingers in front of the neck. Then you position 2 fingers below the mass. Be gentle, always look at the face of the patient to be sure you are not causing the patient discomfort. Then you ask the patient to swallow. Please swallow. As the patient swallows, you see if you can get below the mass. If you can get below the mass, then there is no retrosternal extension. After that, you palpate both lobes of the thyroid gland, one after the other. I want to start with the left. To palpate the left, you place your fingers, your right fingers on the right lobe and stabilize the right lobe. Then you ask the patient to tilt the head toward the left. Tilt your head gently toward the left. The right finger stabilize the right lobe. The index finger on the jaw to keep the head tilted toward the left. This will relax the sternocleidomastoid muscle on the left side to allow you palpate the left lobe. You palpate the left lobe to see if there is any swelling in the left lobe. If there is no swelling of the left lobe, you move on to palpate the right lobe, as in this case. To palpate the right lobe, you tilt the head of the patient to the right. Use your left fingers to stabilize the left lobe. Then your index finger on the left jaw to keep the head tilted toward the right. Then with your right fingers, you palpate the right lobe. There is a mass in the right lobe. Then you characterize the mass. First, check the surface by rubbing your hands around the mass, going around the surface to see if it is smooth, nodular, or irregular. Then you dig your fingers in to palpate for consistency. The thyroid gland most of the times feel firm. Palpate for consistency. After characterizing the mass, then you check for mobility of the mass by grabbing the mass and gently moving it side to side while stabilizing the head. Move it side to side while stabilizing the head. Now you place your left palm under the jaw of the patient and ask the patient to apply a downward pressure. Press my palm down. This put the neck muscles under tension, the sternocleidomastoid, both of them under tension. You try to move from both sides again. Now the movement is limited, showing there is extension to the sternocleidomastoid muscle. After that, you palpate for the pulsations of the carotid arteries, one after the other. With your left hand on the head, you go to the angle of the jaw and palpate for the right carotid pulsation. Then the right hand on the head and your left fingers, you dig into the angle of the jaw and palpate for the left carotid pulsation. You feel for the carotid pulsation to be sure there are pulsations. When there is thyroid malignancy spread to the carotid sheath, the pulsation may not be palpable. You call that Berry's sign. Then after that, you palpate for the regional lymph nodes, starting from the submental, submandibular, the pre-auricular, the anterior, the upper anterior cervical group, the middle anterior cervical group, the lower anterior cervical group, and then the supraclavicular group. To check the supraclavicular, you ask the patient to shrug the shoulders, raise your shoulders, dig your fingers in the supraclavicular region and feel for supraclavicular lymph nodes. Then you come upward, going to the posterior neck group, the lower, the middle, the upper, and then the posterior auricular, and finally the occipital group. After palpating for the lymph nodes, you palpate for scalp swellings. There could be metastasis to the scalp in thyroid malignancies. Palpate the scalp for swellings without disrupting the hair of the patient. After that palpation is completed, then you move on to percussion. You lean over to the anterior chest, starting from the angle of Lewis. You percuss upward to the sternal notch. You expect the percussion notes to be resonant. If they are dull, it will suggest retrosternal extension. Then you auscultate over the superior thyroid pole. You auscultate over the superior thyroid pole for a possible thyroid artery brew. You use the bell of the stethoscope. You auscultate over the superior thyroid pole on the right and then on the left. After that, examination of the neck mass is completed. We move on to check for the eye signs. You start from behind by checking for proptosis, which is also known as Nafziger sign. You ask the patient to hyperextend the neck. Please turn your head this way. Then you adjust yourself and look over the forehead, focusing on the supraciliary ridge. When you look like this, you are not supposed to see the eyeballs. If you see the eyeballs, then there is proptosis, a sign of exophthalmos. And after that, you come in front of the patient, stabilize the head with your right hand, and examine for other eye signs. Please focus on my finger. While the patient is focused on your finger from a considerable distance at eye level, you look at the eyeballs and look out for chemosis, that is conjunctival edema. You also look out for absence of blinking. When there is absence of blinking, a staring gaze, you call that Stellwach sign. Then you look at the upper eyelid and look at the sclera and look out for upper lid retraction. There is upper lid retraction when you can see the sclera above the limbus. In this case, that sign is absent. That sign is known as the Dalrymple sign. Then you gradually elevate your fingers and ask the patient to follow. Follow my finger, follow it, and you focus on the forehead, looking out for wrinkling of the forehead. Look at my finger. Okay, when you see wrinkling, you stop. Then gradually you bring your finger down, ask the patient to follow. Follow my finger. Please follow it. Follow it. When you get to the midline, you drop your finger immediately and see if the patient follows. When there is a sluggishness with that, you say there is lead lag or von Graaf sound. Then you check for ophthalmoplegia, that is paralysis of the extraocular muscles. You can sometimes find that in thyrotoxicosis. It usually manifests as paralysis of the superior rectus and inferior oblique, which causes an inability to look upward and outward. Please follow my finger. Follow my finger. In this case, there is no paralysis. As you put your finger up, you ask the patient, how many fingers do you see? How many fingers do you see? 1. How many fingers do you see here? There is no ophthalmoplegia. Finally, for eye signs, you check for convergence by gradually shifting your finger toward the eyeball. You observe for convergence. Absence of convergence is known as Möbius sign. When you are done with the eye signs, you examine for some other signs in the upper limb. Starting by checking, let me see your palm. You turn and feel the palm of the patient for moistness and warmth. Then you extend the fingers out. Open your fingers out. And you look at eye levels. You look at eye level for tremor. If it's not obvious, you can put paper on both fingers. After that, you check again at eye level for finger clubbing. There could sometimes be finger clubbing as a complication of thyrotoxicosis. Then after that, you focus on the pulse. Specifically, you check the pulse rate and the rhythm. After that, you check for the blood pressure. And then if it's lung case, you examine the heart. But if you are in short case, after checking for the blood pressure, you check for the upper limb proximal myopathy by putting some resistance at the shoulder and asking the patient to raise both hands up. Please raise both hands up. Like this. Raise both hands up. Okay? This patient does not have proximal myopathy of the upper limb. Finally, we go to the lower limb. Extend your legs out. Remove your legs from your slippers. Okay? So first of all, in the lower limbs, you inspect the pretibial region for pretibial myxedema. If you cannot see, you can try to feel for it. This patient does not have pretibial myxedema. Pretibial myxedema is a non-pitting kind of edema you find in the pretibial region. You find it in thyrotoxicosis. After that, you check for ankle reflex by dorsiflexing the forefoot and mobilizing it toward the contralateral foot. As you dorsiflex, you feel the tendon Achilles, that it is tense. And while you look at the calf muscles, you strike the tendon Achilles. In thyrotoxicosis and hyperthyroidism, you can find hyperreflexia. It dorsiflex the other and cross it against the other. You check that the tendon Achilles is tense, then you strike it. Finally, you check for proximal myopathy of the lower limbs by asking the patient to stand up without support. Please cross your hand on your chest, get up. This patient does not have proximal myopathy of the lower limbs. Sit down. That is examination of GOITRE. Thank you.